Welcome to the Deep Dive, the show that cuts through the noise to get you truly well informed, quickly, and thoroughly. Today, we're diving headfirst into a world where absolute precision meets profound human impact. It's really startling when you consider the scale of the problem. A landmark report from 2000, To Err is Human, estimated that nearly 100,000 people were dying each year in the U.S. due to medical errors.
It's a staggering number.
Truly shocking. And what's even more striking for our discussion today is how many of those errors, particularly in surgery, were linked directly to communication breakdowns, something like 40% to 50%.
That high, yes. It's incredible.
That statistic alone really underscores, doesn't it, how leadership is about so much more than just a surgeon's individual technical skill. It's about something far deeper. We're embarking on a deep dive today into leadership in surgery, a field that has dramatically transformed. This isn't just about the mastery of a scalpel anymore.
Wow, not at all.
It's about the intricate art of orchestrating incredibly complex, multidisciplinary teams, often under immense life or death pressure. We're going to unpack why leading these teams is as crucial, maybe even more so, than even the most cutting-edge medical knowledge itself. Our goal for you today is to leave you with an understanding of this topic akin to that of an elite professional in the field. We want you to really master this.
That's precisely our mission for you, the listener. We want to go beyond the surface and provide you with an in-depth, really comprehensive understanding of surgical leadership. We'll delve into every concept, from the foundational principles that guide effective leadership to the subtle nuances of human interaction that truly define success in today's operating room and beyond. This deep dive isn't just about what surgical leaders do, it's about why it matters, how their impact is measured, and most importantly, how these vital skills are cultivated throughout a surgeon's career. You'll gain a mastery of this information that's truly invaluable.
And to achieve that level of insight, we've pulled extensively from a foundational, really authoritative text in the field, SCHWARTZ's Principles of Surgery 11. Now, this isn't a quick read, but we've meticulously distilled the most important nuggets of knowledge and insight, offering you a direct shortcut to being profoundly well-informed on this vital topic. So let's unpack this. Hashtag the evolution of surgical leadership. When you think about the history of surgery, you might picture the surgeon as, well, the lone hero in the operating room wielding absolute authority, almost like a solitary ship captain calling all the shots, you know?
Yeah, that classic image.
In that traditional model, they were solely responsible for the patient, operating very much in a command and control style.
That image, while it was definitely prevalent once, is now profoundly outdated in modern surgical practice. The reality is that surgical care has undergone a dramatic transformation. It's moved decisively from single provider-based care toward a team-based approach. And this isn't just a minor adjustment. It's a fundamental shift that makes collaborative leadership skills absolutely essential. Consider the patient's journey today. It involves far more than just the surgeon. You have a sprawling, multidisciplinary team working in concert. This includes anesthesiologists, managing pain and vital signs, internists handling complex medical conditions, radiologists and pathologists providing crucial diagnostic insights, radiation oncologists involved in cancer treatment.
It's a huge list.
It really is a vast network of nurses, pharmacists, social workers, physical and occupational therapists, and even various hospital staff and administrators who ensure the whole system functions smoothly. The seamless collaboration of all these individuals, skillfully orchestrated by effective leadership, is now absolutely critical for achieving optimal patient outcomes.
And even within that vast and complex team, the surgeon still occupies a truly central role, doesn't he or she? They're not just a technician executing a procedure.
No, definitely not. They are positioned right at the heart of the entire healthcare team, which means they hold immense potential to influence the entire patient experience and ultimately the outcome.
So the potential impact is huge.
Precisely. The tangible benefits of effective surgical leadership are profound and far-reaching. By adeptly leading this diverse, multidisciplinary team, surgeons can directly and significantly improve patient outcomes, substantially reduce the incidence of medical errors, and measurably enhance patient satisfaction throughout their care journey. This goes far beyond mere efficiency. It's about the fundamental safety, well-being, and positive experience of the patient. It truly reinforces why this deep dive into surgical leadership is so utterly vital for anyone aspiring to master this field.
Okay, so given that leadership is so vitally important, it naturally begs the question, are surgeons actually adequately trained for this demanding, multifaceted role? Is the training keeping up?
Unfortunately, based on the current data, the answer is often no, or at least, well, not yet sufficiently. It is, in fact, considered imperative that surgical training programs include formal instruction in leadership. Surveys of surgical residents reveal a pretty striking reality. Many residents felt a lack of confidence in multiple areas of leadership. Conflict resolution especially emerged as a particular area of significant concern.
That's interesting.
Yeah, and while they readily acknowledge that leadership skills are important for their role, a surprising number report themselves as not competent or only minimally competent in these crucial non-technical areas. This isn't about their medical knowledge or surgical dexterity, which are often exceptional. It's about the essential soft skills required to lead effectively.
So while maybe a small number of progressive programs have started to integrate this type of training, the source material unequivocally emphasizes that it's now absolutely imperative that all surgical training programs teach these skills. It needs to be a universal standard.
Absolutely. And academic chairpersons, the leaders at the very helm of surgical departments, they've meticulously identified several critical leadership success factors that go way beyond just clinical acumen. These include the mastery of visioning, communication, change management, emotional intelligence, team building, business skills, personnel management, and systems thinking.
That's quite a list.
It is. And what's particularly telling from their vast experience is the paramount importance they placed on emotional intelligence. They actually deemed it fundamental to their success and its absence the cause of their failures, regardless of their medical knowledge or technical skill.
Wow. So EI is really make or break at that level.
It really seems to be. It highlights a critical, often unaddressed need within traditional medical curricula.
This brings us to a major organizational body in medical education, the Accreditation Council for Graduate Medical Education, or ACGME. They've established 6 core competencies that every residency training program must instill in their trainees: patient care, medical knowledge, practice-based learning and improvement, interpersonal and communication skills, professionalism, and systems-based practice.
Right, those are the big 6. And while these competencies inherently contain principles of leadership, you can definitely see elements of it in interpersonal skills, professionalism, and systems-based practice, for instance.
We took on it.
They touch on it, exactly. But the ACGME, as of today, has not established a formal comprehensive guide on how to effectively teach these nuanced leadership skills. This instructional void is precisely what makes our deep dive so critical. We're essentially providing a detailed roadmap to understand and fill that gap, enabling the cultivation of truly exceptional surgical leaders who possess both clinical brilliance and profound leadership capabilities. We want you, the listener, to really grasp this landscape. #tag defining and layering leadership.
Okay, so how do we even begin to define something as multifaceted and influential as leadership? It seems like everyone has a slightly different, yet equally compelling take on it. Former First Lady Rosalind Carter famously offered this observation: a leader takes people where they want to go. A great leader takes people where they don't necessarily want to go, but where they ought to be.
That's a powerful distinction. It suggests leadership isn't always about the easy path.
Right, it's about growth, maybe pushing boundaries.
Indeed. And John Quincy Adams offered a more expansive view, stating, if your actions inspire others to dream more, learn more, do more, and become more, you are a leader. Very aspirational. From a more academic perspective, leadership can be concisely defined as the process of using social influence to enlist the aid and support of others in a common task.
Social influence, not just authority.
Exactly. What's truly fascinating here is the consistent emphasis across all these definitions on influence and inspiration, rather than mere authority or position. And a critical point to remember, especially in the evolving landscape of surgical teams, is that leadership does not always have to come from a position of authority. It's fundamentally about impact and collective progress, not just a title on an organizational chart. Anyone can potentially lead in certain situations.
That's a powerful distinction. And speaking of organizational success, Jim Collins, the acclaimed author of Good to Great, conducted this groundbreaking 30-year study of Fortune 500 companies. He found a really strong link between robust leadership and sustained corporate success, didn't he?
He did. Collins' research was meticulous. He found that among 11 particularly outstanding organizations that achieved sustained greatness, exceptional leadership was the single major defining characteristic that separated them from their peers. These organizations were led by individuals he famously termed Level 5 leaders, people who embodied a truly paradoxical combination of personal humility plus professional will.
Humility and will. That's an interesting mix.
It is, isn't it? And this model is incredibly relevant to surgical training and career progression. as surgeon leaders are inherently expected to begin at the bottom level and, through study, hard work, and professional development, advance to the ultimate level of executive leadership. It's a journey of continuous growth.
So let's walk through those 5 levels of leadership as Collins meticulously defined them. For you listening, this framework is really helpful for understanding that progression.
Okay. At level 1, you have the highly capable individual. This person excels at their specific tasks, making productive contributions purely through their talent, knowledge, skills, and strong work habits. They're technically excellent, very reliable in their individual capacity.
Got it. The solid performer.
Exactly. Moving up to level 2, you find the contributing team member. This individual not only contributes productively on their own, but also demonstrates the ability to work effectively with others in a group setting to achieve shared objectives. They understand that collaboration amplifies individual effort. They're a team player. Then there's level 3, the confident manager. This leader is adept at organizing people and resources effectively and efficiently toward predetermined objectives. They can reliably make things happen by strategically managing existing structures and processes. They get things done.
The organizer.
Right. At level 4, we see the effective leader. Now, this is where the magic truly begins to happen. An effective leader catalyzes profound commitment to and vigorous pursuit of a clear, compelling vision. They inspire and stimulate the group to achieve consistently high-performance standards, moving beyond mere management to genuine influence and motivation.
So moving from managing tasks to inspiring people towards a vision.
Precisely. And finally, at the pinnacle is the level 5 executive. This executive builds enduring organizational greatness. They achieve this through that unique and often counterintuitive combination of personal humility plus professional will. They are fiercely driven by the organization's success, often to the point of self-effacement, seeing their role as serving the larger institutional mission rather than personal ambition.
Wow, so it's really about serving the mission above ego.
Absolutely. This comprehensive framework truly helps us visualize the developmental journey of an aspiring surgeon leader, moving from individual capability right through to transformative organizational leadership. #tag the pillars of surgical leadership, fundamental principles.
That progression is incredibly insightful, illustrating a clear path forward. Now, let's dive into what the source identifies as the absolute pillars of surgical leadership, starting with what it calls the first and most fundamental principle: vision.
Right, vision. And in the context of surgery, vision is about far more than just, abstract ideals. It's about establishing tangible goals of care for patients, both on a daily basis within a single operation and for long-term strategic purposes, like developing a whole new surgical program. It's essentially a declaration of the near future that inspires and conjures motivation throughout the entire team.
Like a guiding star for the team.
Exactly. Think of it like this. A classic, powerful example is President Kennedy's audacious declaration back in 1961. He committed the U.S. to landing a man on the moon and returning him safely to the Earth before the decade was out. Now, this wasn't just a wish. It was a clear, seemingly impossible vision with a non-negotiable deadline. The unified effort that followed, culminating in Neil Armstrong's famous walk in 1969, perfectly illustrates the profound power of a well-articulated, inspiring vision to drive monumental achievement.
And that concept of a guiding vision connects directly to the daily grind, the very core of surgical practice, right? Surgeons are fundamentally driven by that powerful vision to improve patients' lives. That's their ultimate why.
Exactly. When you look back at the great surgical pioneers, figures like Joseph Lister, Emil Theodor Kocher, Michael E. DeBakey, and Dr. Frederick Banting, they all possessed a vision that truly revolutionized their respective fields and indeed the entire landscape of medicine. Lister, for instance, back in the 19th century, applied Louis Pasteur's germ theory to surgery. He treated a young boy's open compound leg fracture, a condition with a staggering 90% mortality rate at the time, using carbolic acid dressings and meticulous aseptic technique.
Incredible risk back then.
Huge risk. The boy recovered, a seemingly miraculous outcome that led to Lister's famous publication and ushered in the modern era of sterile surgery. His vision was a world where infection didn't automatically doom every surgical patient. And you have Kocher, another visionary. He was the first to master the thyroidectomy, an operation considered virtually impossible then, really fraught with risks. Yet through his dedication and precision, he achieved an astonishing mortality rate of less than 1%. Yeah, ultimately earning him a Nobel Prize for his groundbreaking work on the thyroid's metabolic role. His vision with precision and safety in basically uncharted surgical territory. Michael E. DeBakey's powerful vision pioneered the entire field of cardiovascular surgery. He was an innovator who even invented the Dacron graft, a revolutionary device that has saved millions of patients' lives and really enabled the development of modern endovascular surgery. And Dr. Frederick Banting, the youngest Nobel Prize recipient in physiology or medicine, envisioned discovering the biochemical link between diabetes and glucose homeostasis, a pursuit that led directly to the life-saving discovery of insulin. In retrospect, the power and clarity of their visions were truly remarkable, and their willingness and dedication were profoundly inspiring. By studying these monumental careers, surgical trainees can truly grasp the potential impact of a well-developed, deeply held vision on patient care and medical progress.
So for you, our listener, how do you cultivate such a powerful vision in your own field? The source suggests a simple yet profound, actionable insight. Brainstorming the answers to just 2 questions. Which disease needs to be cured, and how can it be cured? Recording these answers, maybe just committing them to paper in a notebook, is the crucial first step. It helps define and articulate that shareable vision, making it real and tangible.
But a great vision isn't enough on its own, right? It requires widespread buy-in. Leaders also need to inspire their team and truly understand what motivates them. This brings us to Simon Sinek's transformative Start With Why concept, which is a truly profound insight into human behavior and motivation. Sinek argues that people do not follow leaders because of what they do. People follow leaders because of why they do what they do.
The why behind the what.
Exactly. It's not about the product or the policy. It's about appealing to fundamental beliefs, values, and attitudes that resonate deep within people.
And what's fascinating is that there's a compelling biological reason why this approach works so effectively, linking directly to how the human brain actually processes information.
Yes, it's a brilliant insight into neuroscience. Our brains have distinct areas for different functions. The what and how of things like specific policies, procedures, or data correlate to the neocortex. That's the newest and most rational part of our brain. Information processed here is subject to analytical scrutiny and can be easily rejected if it doesn't align with logic or existing beliefs.
Makes sense. The logical brain pushes back sometimes.
Right. However, the why appeals directly to the limbic brain, which is an older, much more emotional part of our brain. When a vision touches this deeper emotional core, when it aligns with our core values and beliefs, it is far more likely to be accepted, embraced, and acted upon.
So you're bypassing the analytical filter and going straight for the emotional core.
In a way, yes. Consider this compelling example from surgical practice. A surgeon leader wants to implement a new perioperative checklist to reduce surgical errors. Now, if the leader approaches the team purely with the what rational arguments about the checklist's efficiency or how it incorporates the best evidence, appealing solely to their neocortex, the team might perceive it as just another piece of paperwork.
Yeah, I can see that happening. More bureaucracy.
Exactly. They might resist, seeing it as an additional burden, or subtly undermine its implementation, but a leader who understands human motivation will start with why. Before even discussing the checklist itself, they might speak passionately of the shared mission to offer the best patient care possible. They might ask the team to imagine how they would want a beloved family member treated, or emphasize the potential for careless error to lead to profound patient harm and even team embarrassment. These arguments appeal directly to the emotional limbic brain, to the team's shared belief system and ethical core. The team then becomes genuinely receptive to implementing the checklist, not just because they intellectually understand its utility, but because they emotionally believe in the surgeon leader's vision for optimizing patient safety and care.
That's a huge difference, moving from just intellectual understanding to genuine, visceral, emotional buy-in. And once that belief is inspired, it needs to be sustained, right? Surgery, by its very nature, demands extraordinary dedication and great personal sacrifice. Any truly transformative vision implies that change and difficult work will inevitably be required.
Absolutely. For this reason, surgeon leaders must establish visions about which they are deeply passionate and committed, as this passion provides them the inner strength and resilience to overcome the inevitable obstacles and setbacks. Jim Collins also emphasized that great leaders should be selective about which options they pursue. This isn't about avoiding work. It's because each opportunity and idea requires great effort, and only a few can be fully realized with excellence.
So focus is key.
Focus is absolutely key. Leaders need to deeply understand what truly drives their organization's economic engine, what truly brings better patient care, attracts more patients, or enables new, innovative treatments. The best opportunities lie where talent and ability align, allowing leaders to truly be the best in the world at doing something specific and impactful.
Play to your strengths, essentially.
Right. Once that clear vision is set and the strategic project chosen, the leader must then master the art of generating momentum. Collins vividly describes this as the flywheel effect. It begins with A, initial consistent steps forward, which then lead to B, an accumulation of visible, tangible results. These positive results then naturally cause C, a realignment and renewed enthusiasm of the team, which in turn creates D, an accumulation of momentum, propelling the team toward even more significant steps forward.
Like pushing a heavy wheel, it's hard at first but gets easier as it spins.
Exactly that image. This careful attention to these foundational principles, vision, belief, and momentum, is absolutely essential for building a successful surgical career, developing a thriving department, or even launching an entire division or research initiative.
That brings us to what the source calls the willingness principle, which is defined as the active commitment of the leader toward his or her vision. It's about more than just having a vision. It's about the active, consistent pursuit of it, facing challenges head on.
And this willingness to lead is indeed a key characteristic of all great leaders. Think of Dr. Martin Luther King Jr., who championed the civil rights movement with an incredibly powerful vision of equality, committed to nonviolent methods. He pursued this vision at a time of immense personal risk, enduring harassment, threats against himself and his loved ones, and constant opposition. King, a young, highly educated pastor with job security and a family, was willing to accept enormous responsibility and personal risk to lead a nation toward his vision, for which he later deservedly won the Nobel Peace Prize. His commitment was unwavering.
A profound example of willingness.
Truly. This same profound willingness to lead is a fundamental necessity for anyone aspiring to be a surgeon. Entering the surgical theater means accepting the profound responsibility to care for and operate on patients, despite inherent risks, immense burdens, and often emotionally taxing situations. They do so, driven by a deep, almost altruistic belief in the improved quality of life that can be achieved for their patients. Surgeons also willingly embrace the responsibility of leading surgical teams and guiding surgical trainees. The tremendous sacrifice required during residency, the steep learning curve, the constant anxiety, the incredibly long work hours, the significant time away from family and personal life all reflect an active, passionate commitment to excellent patient care and an innate willingness to lead based on altruism and a sense of duty. To truly deliver the highest possible level of care, surgeons must continuously recognize and refine these deeply personal leadership skills.
And a crucial ongoing part of that commitment is the willingness to learn, a profound commitment to lifelong learning in the ever-changing field of modern surgery. The landscape is constantly shifting, isn't it?
Absolutely. It never stands still. We operate within incredibly dynamic healthcare systems characterized by relentless scientific discovery, rapid technological innovation, and evolving patient needs. Consider the explosion of genomic medicine and personalized surgery, for instance. Understanding specific genetic markers like BRCA1 mutations now guides prophylactic mastectomies for breast cancer risk reduction, and RET proto-oncogene mutations inform the approach to thyroidectomies.
So genetics is directly changing surgical decisions.
Directly. These are just two examples of how genomic information is now precisely guiding surgical care, fundamentally transforming the field. We've also witnessed rapid technological advances like minimally invasive surgery, robotic surgery, and the widespread adoption of electronic medical records. Laparoscopy and endovascular surgery, once really cutting-edge techniques, quickly became the standard of care over the past 3 decades, leading to shorter hospital stay, quicker recovery, and a kinder and gentler manner for patients.
Huge benefits for patients.
Huge. This rapid, continuous evolution means that surgical leadership training must emphasize and facilitate the continual pursuit of knowledge. A leader simply must be a lifelong learner.
So how do surgeons stay current?
Fortunately, surgical organizations and professional societies provide continuous avenues for this lifelong learning. There are countless local, regional, national, and international meetings that offer continuing medical education credits, which are often formally required for medical license renewal. The American Board of Surgery, for example, mandates meaningful CME for certification maintenance. Beyond traditional conferences, the rapid expansion of web-based education and mobile handheld technology now provides incredibly powerful tools to minimize non-productive time and maximize learning.
Right, access information anywhere.
Exactly. Giving surgeons quick, on-demand access to foundational texts, the latest literature, and even surgical videos in real time. The next evolution in surgical education is clearly simulation training, with sophisticated modules available for laparoscopic and Da Vinci robotic devices, allowing for risk-free practice. The ACGME, recognizing this paramount importance, explicitly includes lifelong learning and effective information access as key requirements for residency accreditation, underscoring its foundational role in modern surgical leadership.
Okay, next pillar. The willingness to communicate effectively. This is presented as something that directly impacts patient care in our increasingly complex modern healthcare delivery systems. Sounds critical.
This point cannot be overstated. It truly is a cornerstone. That seminal 2000 U.S. Institute of Medicine report, To Err is Human, Building a Safer Health System, estimated that a staggering 100,000 deaths annually were attributable to medical errors in the U.S. And critically, communication errors were identified as one of the most common causes, particularly in the surgical setting.
Wow, communication errors causing that many deaths.
It's sobering. The Joint Commission, a leading healthcare accrediting body, even identifies miscommunication as the leading cause of sentinel events, those serious, usually preventable adverse events that result in patient death or serious injury. These errors lead to significant delays, wasted time for staff, and, most importantly, serious adverse patient events. Conversely, there is a clear, strong correlation between effective communication and improved patient outcomes and significantly less medical litigation.
So good communication saves lives and reduces lawsuits.
Essentially, yes. The problem isn't simply a failure to transmit information. Communication errors are complex and deeply rooted in systemic and interpersonal dynamics. They often stem from hierarchical differences within the team.
Like junior staff being afraid to speak up.
Exactly. Concerns with upward influence, conflicting roles and role ambiguity, and underlying interpersonal power and conflict. Errors frequently arise from perceived limited channels of communication in hostile critical environments, where psychological safety is low. The solution, therefore, is multifaceted. Surgeons must learn to communicate in an open, universally understood manner and, critically, remain receptive to any team member's concerns, regardless of their position or title.
So it's about creating a safe space to speak up.
Precisely. Studies show that the simple act of explicitly stating daily goals in a standardized way in an ICU setting reduced patient stay and significantly increased resident and nurse understanding of care goals. Standardized daily team briefings have demonstrably improved staff turnover, enhanced satisfaction, and even prevented serious errors like wrong site surgery. In cardiac surgery, improved communication between the operating room and the post-anesthesia care unit, PSIU, has been shown to reduce adverse outcomes. It's about clear, consistent, and open channels.
So it's not just about what you say, but fostering an environment that inherently supports clear, open communication. What are some of the behaviors to actively avoid, or conversely, positive ones to cultivate to ensure that vital exchange?
Right. There are definite do's and don'ts. Certain behaviors are considered patient hazards and should be strictly avoided. These include a surgeon's absence from the operating room when needed, playing loud music that distracts or hinders communication, making inappropriate or unprofessional comments, or using a raised voice or condescending tone towards team members.
Creates a terrible atmosphere.
Terrible. On the positive side, behaviors like actively leading the timeout process, where the entire surgical team pauses before incision to confirm critical patient and procedural information, and using closed-loop communication technique.
Can you explain closed loop quickly?
Sure. It's where a sender gives a message, the receiver repeats it back accurately, and the sender confirms it was heard correctly. Simple, but incredibly effective. These techniques have been demonstrably shown to improve patient outcomes. Standardization plays a huge role here, too. Beyond the universal timeout, systems like Kaiser Permanente's "I need you now" phrase ensure immediate, understood urgency in critical situations.
And what about communicating with patients themselves? That's a whole other layer, especially now with Dr. Google.
It is, and it's equally vital, especially in the modern era, where patients have unprecedented access to health information online and often struggle to evaluate its source or validity. There's a known discrepancy between a surgeon's self-perceived ability to communicate and a patient's actual satisfaction with that communication. What the surgeon thinks they conveyed isn't always what the patient heard or felt.
The perception gap.
Exactly. A patient's perceived interaction with their physician profoundly impacts their health outcomes, their likelihood of filing a malpractice suit, and even, increasingly, financial reimbursement for the healthcare institution. Good bedside manner, characterized by genuine empathy and clear explanation, has been shown to decrease litigation risk, even when an error actually occurs.
Really? Even if something went wrong?
Yes. Physicians who demonstrate genuine concern, truly know their patients as individuals, and actively share decision-making are far more likely to be trusted and less likely to be sued. Recognizing this, organizations like the Agency for Healthcare Research and Quality and the Centers for Medicare and Medicaid Services now incentivize strong physician-patient communication through patient satisfaction programs like HCAHPS and CGCHPS, tying it directly to hospital performance metrics.
This sounds like a potential minefield. And in complex, high-stakes environments like surgery, numerous conflicts are bound to arise on a daily basis. So the willingness to resolve conflict must be absolutely critical for a leader.
It is, without question. The source emphasizes that effective conflict resolution requires objectivity, personal flexibility, and deep self-awareness. There can often be a profound gulf between a surgeon's self-perception of their collaborative skills and how others perceive them. One striking study showed surgeons rated their operating room collaboration at 80%, while nurses on the same teams rated it at only 48%.
Wow, that's a huge difference in perception.
It is, and it highlights the need for external feedback and humility. Systematic inclusion of modern conflict resolution methods that incorporate all team members' views, fostering an environment where everyone feels heard, helps maintain objectivity and identify the true root causes of disagreement. Reflection, though often overlooked in the demanding environment of residency, is absolutely critical for understanding one's own actions, biases, and emotional triggers. Objectivity, coupled with empathy, forms the foundation for effective conflict resolution, ultimately leading to better team satisfaction and, most importantly, optimal patient care.
So what do these modern techniques look like in practice?
Well, they're based on objectivity, a willingness to listen actively, and a principled pursuit of solutions. One highly effective style is the abundance mentality model. This approach seeks solutions that benefit all parties involved, rooted in core organizational values, rather than relying on a traditional fault-finding or win-lose approach.
Aiming for win-win.
Exactly. In surgery, this means elevating any conflict to the higher unifying goal of improved patient care. For example, quality improvement conferences, which were historically and often negatively referred to as morbidity and mortality, or M&M conferences.
Right, the blame sessions.
Yeah, they often felt like that. Now they actively focus on systemic practice improvement, analyzing processes, and identifying areas for growth, rather than simply assigning blame for complications. This contrasts sharply with the traditional command and control technique based on fear and intimidation, which is now unequivocally no longer welcome in modern surgical settings and can, in fact, lead to severe professional sanctions or even lawsuits.
That old style is just not acceptable anymore.
Not at all. Another intuitive and objective method that directly parallels surgical practice is the history and physical model of conflict resolution. It thoughtfully breaks down the process into 7 distinct steps, much like caring for a surgical patient.
Okay, walk us through that. It sounds intriguing.
Sure. First, the history involves gathering subjective information from all parties involved, approached with empathy and a desire to understand perspectives. Second, laboratory studies entails collecting objective data and facts relevant to the conflict. Third, a differential diagnosis is formulated to identify possible root causes and contributing factors. Fourth, the assessment plan is developed in everyone's best interest, discussed openly and compassionately, outlining potential solutions. Fifth, preoperative preparation involves necessary consultations and ensuring informed consent and buy-in from all involved parties for the proposed plan. Sixth, the operation is the actual implementation of the agreed-upon plan, often including a timeout moment to confirm understanding. And seventh, post-operative care involves communicating the outcome, ensuring follow-up, and correcting any unforeseen complications or lingering issues.
That's fascinating, applying the clinical method to interpersonal problems.
Exactly. It's an objective, respectful method that's proving invaluable for surgical trainees and leaders navigating complex interpersonal dynamics.
Moving on to another crucial yet elusive resource, time. You often hear that time is the most precious resource, as it cannot be bought, saved, or stored. For surgeons, with their intense schedules, this must be profoundly true.
It's profoundly true for anyone in a high-demand profession, but especially so in healthcare. Effective management of time is essential for a productive and balanced life for everyone within a healthcare organization. For surgeons and trainees, this is particularly vital due to ever-increasing demands, more complex cases, administrative burdens, highly regulated environments, and strict regulations on limitation of work hours for trainees.
Right, the work hour restrictions.
All these demands combine to create enormously stressful environments, which unfortunately can lead to severe consequences like burnout, drug and or alcohol abuse, and poor performance for individuals. A time motion study of general surgery trainees even showed that senior residents spent a significant 13.5% of their time on low-service, low-educational value activities, time that could be strategically repurposed for education, research, or even just to reduce overall work hours and get some rest.
Wow, 13.5% on low-value stuff. That's a lot.
It is. Two key principles from management theory shed considerable light on common time management challenges. Parkinson's law from 1955 famously states that work expands to fill the time available for its completion.
Meaning if you give yourself all day for a task, it'll take all day.
Pretty much. This often means we inadvertently end up spending disproportionate time on insignificant tasks simply because that's the allocated time. Pareto's 80-20 principle, another powerful concept, suggests that 80% of goals are achieved by 20% of effort, implying that the final, seemingly small 20% of a task can take 80% of the total effort.
Getting those last details perfect takes forever.
Right. This highlights the critical need for careful planning and prioritization to truly maximize impact and focus your energy where it counts most.
So, with those principles in mind, what techniques truly help surgeons and other professionals manage this unbought, irreplaceable resource effectively?
Well, the basic prioritized list is a common starting point for many, but it often falls short of aiding the user in allocating time wisely because it doesn't really account for urgency or impact effectively. A much more robust and strategic technique is the time management matrix technique, popularized by Stephen Covey, which plots activities based on their importance and urgency, yielding 4 distinct quadrants.
Okay, let's quickly outline those quadrants for our listener so you can visualize how your own time might be categorized.
Absolutely. Quadrant I contains activities that are both important and urgent. These are your genuine emergencies, unplanned crises, putting out fires, often represent a state of disorganization or reactive management. Surgeons can frequently find themselves habituated to operating predominantly in this quadrant due to the acute, critical nature of their work.
The firefighting zone.
Exactly. Quadrant 2 is where you ideally want to channel the majority of your energy and strategic effort. These activities are important but non-urgent. This is the high-yield quadrant. It encompasses proactive efforts like planning, creative activity, building relationships, and maintaining productivity, all crucial for long-term success and well-being. Too often, professionals get stuck perpetually responding to Quadrant 1 crises and neglect Quadrant 2.
So this is where the real progress happens.
That's the idea. Quadrant 3 covers activities that are non-important and urgent. These are often interruptions that feel pressing because they demand immediate attention from others, like some emails or calls, but they don't significantly contribute to your core important goals. They're often other people's priorities masquerading as yours.
The urgent but ultimately trivial stuff.
Right. And finally, Quadrant 3 contains activities that are non-important and non-urgent. These are typically time-wasting activities that offer little to no value. Think mindless scrolling, busy work, etc.
The escape zone, maybe, but not productive.
The fundamental goal, according to this matrix, is to strategically shift energy from the reactive, stressful quadrant, the force, and the distracting quadrant, third, to the proactive, high-yield quadrant, 2. This shift significantly reduces stress, actively prevents burnout, and allows for a concentrated focus on long-term goals and strategic initiatives. Another effective model discussed is the 6 areas of interest. This involves performing a detailed time motion study of your own life, analyzing 6-hour increments over a full week to account for all 168 hours.
Oh, that's detailed.
It is, but revealing. You then select 6 broad categories for your life, like family, clinical care, education, health, community service, or hobbies, and consciously set a daily or weekly goal in each. Systematically monitoring these goals helps you achieve a truly balanced set of objectives and measurably improves your overall quality of life by intentionally eliminating or reducing time-wasting activities.
It sounds like adopting a formal time management program isn't just about getting more done, but about achieving a higher quality of life and ultimately enabling even better patient care.
Precisely. It's absolutely essential for excellent clinical care while simultaneously fostering a more balanced lifestyle for the demanding profession of surgery. It's a win-win for both the professional and the patient at the end of the day.
Given the immense demands on surgeons, the long hours, the emotional weight, the constant pressure, It's unfortunately not surprising, I guess, to learn that they face unique stresses that set them apart.
It's a painful truth, and one that the medical community is increasingly acknowledging and trying to address. Surgeons experience increased rates of suicide, depression, substance abuse, marital and family problems, and other stress-related health effects when compared to the general population.
That's really concerning.
It is. Specific risks include higher suicide rates among those who are divorced, widowed, or never married. Depression rates can be as high as 30% among trainees, a truly alarming figure. And unfortunately, prescription drug abuse is higher due to their ability to self-medicate more easily. Marital unhappiness is often linked to what's called the psychology of postponement, where personal needs and well-being are constantly pushed aside, combined with compulsive personality traits often reinforced during demanding training, and a chronic lack of work-life balance.
And do they seek help?
That's the other problem. A significant and deeply concerning barrier to seeking help for these issues is the pervasive fear of losing their medical license if they admit to mental health struggles or substance use issues.
So there's a stigma preventing them from getting help.
A huge stigma, yes. However, there are crucial protective factors that can mitigate these risks. These include establishing and maintaining regular exercise programs, consistent maintenance of routine medical care, and regular health screening. Simple self-care, basically. The source also highlights that religious practices, reflective writing, and actively maximizing work-life balance can be profoundly protective.
Finding meaning and balance outside work.
Exactly. The increasing attention to physician wellness has fortunately led to the development of departmental wellness programs, which represent a crucial opportunity for surgeons to demonstrate their leadership not just for patients, but in helping their peers at risk, fostering a supportive environment for everyone.
That's such an important point, the idea that no single surgeon can go it alone. The source clearly states that no single surgeon leader can exercise complete control. It takes a team of leaders. This immediately emphasizes the profound importance of effective recruitment, right? Building the right team.
Indeed. Building the right team is paramount and requires leaders who actively seek out and embody those level 5 leader characteristics we discussed earlier: personal humility and professional will. The era of self-proclaimed giants who dominated and suppressed alternative points of view is, thankfully, giving way to the undeniable need for authentic leaders who have high ethical standards and well-developed non-technical skills.
The old surgical stereotype is fading.
Hopefully, yes.
Yeah.
The very essence of a leader in this modern context is one who enables others to succeed. It's imperative that leaders are not only skilled themselves, but also build teams where talented individuals are thoughtfully placed in the right job for their skills and aptitudes. Get the right people on the bus and in the right seats, as Collins would say.
Right.
And underpinning all effective teamwork, fostering cohesion and high performance, is the indispensable element of trust. Teams that trust each other work synergistically. Those that don't invariably struggle and fail to reach their potential. Trust is the glue.
Building a capable team is one challenge, but creating a specific culture of empathy, patient family-centered care, and personalized surgery sounds like the most challenging of all the surgeon leader's tasks. That seems like a deeply ingrained shift in mindset, not just structure.
It truly is a monumental undertaking. Instilling a positive and empathetic culture demands immense discipline and consistency because it takes considerable time to fundamentally change how people think, feel, and behave. It's not a quick fix. Organizational culture is deeply intertwined with and ultimately built around the leader's vision and values. It reflects what the leader prioritizes and models every single day. And staying true to those core values, particularly when conflicts arise or when external pressures push against them, can be challenging, requiring unwavering commitment and integrity from the leader. This cultural transformation is continuous and requires constant reinforcement and attention. It's never done. Hashtag the impact and styles of leadership.
Let's dig into why individuals choose to lead. It raises that age-old question. Are leaders born or made? The source suggests the best evidence points to, well, both.
That's right. While some innate qualities might provide a predisposition, leadership potential is widely seen as a skill we all possess to some degree. But critically, it can be formally trained, learned through observation, and honed with practice. It's like a muscle that strengthens with use. The positive effects of effective leadership are profound and widely documented. impacting innovation, diversity, culture, and overall quality within an organization. For surgeons, specifically, strong leadership skills are not a luxury, but an absolute essential for the delivery of quality patient care.
So it's a core competency.
It really is. This makes it an undeniable duty for them to actively cultivate these skills throughout their careers.
Are there personal benefits too?
Beyond the collective benefits for the team and patients, there are also significant individual advantages for surgeons who embrace leadership, including recognition from one's peers, opportunities for promotion, and a greater degree of autonomy in their practice. However, modern leaders are increasingly expected to display humble accomplishments and a service-oriented mindset to be truly effective and inspiring. The ego needs to take a back seat.
Right, that level 5 humility again.
Exactly. But beyond these personal gains, there are often more selfless motivations driving surgeons to lead. Leadership as a powerful tool to help make a difference in the lives of patients and the trajectory of healthcare. A path to a fulfilling career as an educator, finding deep satisfaction in seeing others succeed and grow. A profound sense of selfless service to their profession and community. Or simply a strong desire to solve complex problems that impact many. Whatever the underlying motivation, given their central role at the head of patient care teams, surgeons have a clear and pressing duty to develop some skill in leadership for the profound benefit of themselves, their departments, and most importantly, their patients.
And what about the actual measurable effects of leadership on things like healthcare costs and crucial clinical outcomes? This is where formal leadership education truly shows its quantifiable value, presumably.
Indeed, the evidence is compelling and growing. Large observational studies have provided significant findings. For instance, abusive supervision or over-controlling methods by leaders have been demonstrably shown to reduce team cohesion and collective efficiency, and significantly decrease psychological safety within the team.
Meaning people are afraid to speak up or make mistakes?
Exactly, leading to a stifling environment where errors are actually more likely. Conversely, surgeons perceived as having positive leadership characteristics by their staff have been linked to a statistically significant lower 30-day all-cause mortality for their patients.
Wow, lower mortality, that's a direct link.
It is. This is attributed to their ability to create a genuine culture of safety, where staff feel truly empowered to speak up about concerns, offer suggestions, and act autonomously when errors are noticed or prevented.
So, good leadership creates a safer environment.
Precisely. This directly connects to patient safety and the critical role of non-technical skills. The Two Errors Human report, as you mentioned right at the top, estimated nearly 100,000 annual deaths from medical errors, with a staggering 40% to 50% of errors in surgery, specifically linked to communication breakdown. The Multi-Factor Leadership Questionnaire, or MLQ, which measures transformational leadership behaviors like charisma, inspired motivation, intellectual stimulation, and individualized consideration, shows powerful correlations. Video analysis of complex operations found that surgeons scoring just 1 point higher on transformational leadership exhibited 3 times more information-sharing behaviors, 5 times more positive rest behaviors, and 10 times more supportive behaviors during operations.
That's a huge difference from just 1 point.
It is. And crucially, they displayed poor leadership behaviors 12.5 times less frequently. These transformational qualities clearly help prevent serious errors by fostering a collaborative and communicative environment. The field of trauma offers the largest body of formal study on leadership's positive effects, consistently showing that strong leadership skills in trauma teams measurably improve both the speed of resuscitation and completion of the initial trauma evaluation. Saves critical time.
So in emergencies, good leadership is vital.
Absolutely. While it's true that no one optimal style of leadership fits all situations, some moments call for empowering the team, while others demand a more directive approach. Depending on the team's experience and the urgency of the situation, educated leaders should possess the flexibility and insight to switch easily between styles as needed. Adaptability is key.
Makes sense. What about protecting the organization itself?
Leadership styles also profoundly affect responses to patient safety concerns and are crucial for protecting the organization itself. Surgical leaders must effectively adopt a supervisory role while simultaneously, and perhaps paradoxically, creating a robust safety culture. This means actively encouraging frontline staff to participate in safety improvement initiatives, establishing a sense of staff, ownership of safety, and critically protecting whistleblowers who report concerns from retaliation.
Creating that psychological safety again.
Exactly. It requires fostering a deep sense of psychological safety organizational fairness and continuous learning, where subordinates are given appropriate authority, autonomy, and latitude to perform their jobs and contribute to patient safety.
And does formal training make a difference here?
Demonstrably so. For instance, the Veterans Health Administration System's medical team training program resulted in an impressive 18% decrease in 30-day mortality and a 17% decrease in 30-day morbidity across participating hospitals after implementation.
18% decrease in mortality, that's huge.
It's massive. At an organizational level, an empowering leadership style can significantly improve process of care protocols and increase overall efficiency, such as reducing operating room turnover times. It can also lead to a reduction or even elimination of hospital-acquired infections, which directly impacts institutional reimbursement. Ultimately, effective leadership reduces medical errors, dramatically improves patient satisfaction, and positively impacts an institution's overall financial performance. Conversely, a traditional command and control style leadership negatively impacts psychological safety, leading to toxic work environments that break down even the best clinical processes and compromise patient care. The old ways are just demonstrably harmful.
So we're seeing clear, quantifiable positive impacts across the board, from individual patient outcomes to organizational efficiency and financial health. Now let's talk about another crucial dimension of modern leadership, the importance of diversity in leadership within the field of surgery. The past quarter century has seen a steady and welcome increase in diversity within the field.
It has, and it's a vital area for continued progress. As of 2015, women represent 38% of surgical trainees and 10% of academic professors, a representation that has impressively doubled in just 20 years. Still work to do, but progress. African Americans comprise 6% of medical school graduates, 6% surgical trainees, and 2% to 4% of professors, while Hispanics account for 5% of graduating medical students, 9% of general surgery trainees, and 4% to 5% of persons at all levels within surgery.
Why is this diversity so crucial?
Well, beyond the fundamental reasons of equity and representation, this increasing physician diversity is incredibly crucial because it may help to address disparities in social determinants of health by better reflecting and understanding the diverse patient population served. Having providers who understand different backgrounds can improve care.
Makes sense. What are the challenges?
The primary challenge, or what's sometimes called a bottleneck in diversity, unfortunately occurs right at the very beginning of the pipeline, at the level of the medical school application pool. This is largely attributed to educational deficiencies at the primary, secondary, and collegiate level in underserved communities. Fixing this requires systemic change way before medical school.
So it's a long-term fix.
Exactly. To address this fundamental issue, programs like the University of Michigan's Pipeline program are making a difference. These initiatives pair grade school and high school students with physicians, providing invaluable experiential learning, one-on-one mentoring, opportunities for presentation skill development, and crucial networking. It's therefore important for departments of surgery to develop a comprehensive diversity program for recruitment throughout the career spectrum. Multi-institutional blinded studies further confirm that formal leadership and diversity training improves diversity leadership and strategic human resource management within healthcare organizations. Training helps.
It's clear that leadership is built upon fundamental principles. But how are those principles actually put into practice by a surgeon leader? Daniel Goleman's landmark study, published in the Harvard Business Review, identified 6 distinct leadership styles, all rooted in emotional intelligence.
Right. Goleman's work on EI and leadership styles is foundational here. Emotional intelligence, in this context, is defined as the ability to recognize, understand, and control the emotions in others and ourselves. By learning and understanding these different styles, surgeons can critically recognize their own default leadership style, truly understand its effect on the team dynamic, and most importantly, know when the situation demands a change in style for the best possible outcome. These different styles are truly tools in a leader's adaptable toolkit.
Okay, let's explore them. First up, the coercive style. This leader essentially says, do what I tell you. It sounds quite blunt, maybe even harsh.
It is blunt. This style demands immediate compliance and represents the command and control approach that, while historically dominant in surgery perhaps, is far less effective today. While it might seem efficient in the very short term, excessive coercive leadership erodes team members' sense of responsibility, stifles motivation, diminishes their sense of participation in a shared vision, and ultimately compromises performance.
Yes, morale.
Completely. It should be used sparingly and is truly best suited for emergencies, where rapid, unquestioning action is required, like an acute hemorrhage in the OR. It's a style to be pulled out only when absolutely necessary, not as a default.
Got it. Next is the authoritative style, which sounds a bit more inspiring. Come with me.
The authoritative leader excels at mobilizing the team toward a common grand vision, while simultaneously allowing the team freedom to innovate, experiment, and devise its own means to achieve that vision. Goldman's research indicates this is often the most effective style for long-term success. These leaders naturally exude self-confidence, demonstrate empathy, and possess clear proficiency, making them ideal when a significant shift in paradigm is needed within a department or a new direction is being forged. They lead by inspiration and clarity of purpose. Sets the vision.
Then there's the affiliative leader, focused on building connections and emotional rapport. The people person style.
Kind of, yeah. This style creates harmony and builds strong emotional bonds within the team by emphasizing empathy, fostering positive relationships, and promoting open communication. Affiliative leaders are typically generous with positive feedback and are excellent at boosting morale. The primary downside is that this style can allow poor performance to go uncorrected if the leader is too hesitant to provide constructive criticism or address underperformance directly, maybe for fear of upsetting harmony.
Avoids confrontation.
Can do. However, it's incredibly useful for motivating people during highly stressful circumstances or healing rifts and repairing strained relationships within a team. Great for team cohesion.
Okay. The coaching style sounds like it's deeply focused on individual development and growth, like a sports coach for surgeons.
It absolutely is. This style focuses on developing people for the future, truly embodying leadership through mentorship and personal investment. The coaching leader gives challenging tasks designed for growth, provides specific counseling, encourages continuous improvement, and thoughtfully delegates responsibilities to empower team members. Unlike the affiliative leader, the coach actively helps individuals identify their weaknesses and improve their performance, clearly connecting their daily work to their long-term career aspirations. This style excels at building overall team capabilities and fostering individual excellence.
But it has limits.
Yes, it does not work well when team members are defiant and unwilling to change or learn, or if the leader themselves lacks proficiency in the skills they are trying to impart. You can't coach what you don't know, and you can't coach someone who refuses to learn.
Makes sense. Next, the democratic leader, who seems to place a high value on collective input and consensus. Everyone gets a vote.
Not quite everyone gets a vote on everything, but the democratic leader forges consensus through participation, actively listening to and genuinely valuing each team member's input before making decisions. This fosters buy-in and a sense of shared ownership. However, this isn't the best choice in an emergency where time is critically limited, or if teammates lack the necessary informed guidance to contribute meaningfully. It can also be exasperating if a clear, decisive vision does not arise organically from the collaborative process, leading to analysis paralysis or stagnation.
So it can be slow.
It can be. It is most appropriate when seeking broad team consensus, to quell existing conflict or to create harmony after a period of discord. Good for building buy-in on non-urgent matters.
And finally, the pace-setting leader, who seems to lead by very demanding example. The high achiever who expects everyone else to keep up.
That's a good way to put it. The pace setter sets incredibly high standards for performance and exemplifies them through their own tireless work ethic. They quickly identify poor performers and demand more, but critically, this style does not typically build the skills of those who can't keep up. The pace setter often ends up taking over tasks themselves or redelegating to more capable individuals. The phrase, "do as I do now," perfectly captures this style.
Sounds exhausting for everyone.
It can be. It works well for achieving high-quality results when you have motivated, already capable teams. However, the risks are significant. Pace setters can easily become micromanagers, leading to leader burnout from carrying too much. Team members can also feel overwhelmed and demoralized by the relentless demands for excellence without an empathic counterbalance or support for skill development. It can crush morale if overused.
So it's definitely not about picking one style and sticking to it rigidly then. It sounds like true mastery lies in adaptability, in choosing the right tool for the job.
Exactly. That's the key takeaway from Goldman's work. The most successful leaders do not rely only on one leadership style alone. Instead, they skillfully use several of them seamlessly, depending on the specific situation and the individual team members at hand. Mastering the authoritative, affiliative, democratic, and coaching styles is particularly crucial, as these styles serve as essential tools to guide a team towards a shared vision or goal. This adaptability and situational awareness are absolutely key to modern surgical leadership, and indeed leadership in any complex environment. You need the whole toolkit. Hashtag formalizing leadership development.
Given everything we've discussed about how effective leadership profoundly improves patient outcomes, it seems unequivocally obvious, really, that these skills must be taught formally, systematically. You can't just hope people pick it up.
It is an urgent, undeniable need. While the ACGME core competencies certainly reflect the need for these skills, surgical trainees, particularly chief residents who are often thrust into significant leadership roles, frequently express a self-perceived lack of leadership ability. A comprehensive survey on 18 core leadership skills among residents showed that 92% rated all these skills as important for their careers, yet over half rated themselves as minimally or not competent in 10 out of 18 skills.
Over half felt minimally or not competent. That's a huge gap.
It highlights a significant and concerning gap between perceived importance and actual competence. The good news is there's a growing demand from residents and junior faculty alike for formal leadership training. They recognize its importance themselves and are asking for it.
So the demand is there. What exists currently?
Well, some extracurricular leadership programs do exist today, often attracting physicians pursuing MBAs, and many institutions offer their own internal leadership retreats or seminars. The ACGME itself hosts workshops, though often geared more towards other specialties like pediatrics, family medicine, and psychiatry. The American College of Surgeons also holds an annual leadership conference that focuses on critical attributes, consensus building, team development, and conflict resolution. These existing programs, though maybe not universal or fully integrated yet, have been received well, signaling a clear and widespread demand for formal, structured leadership development in surgery.
So if there's such a clear need and demand, how do we design truly effective training programs to bridge this critical gap and cultivate the next generation of surgical leaders? What makes a program work?
Success in designing these programs hinges on several key methodological considerations. First, participant selection is crucial, identifying the right participants at the right time in their career. Ideally, these are junior surgeons new to practice who are inherently open to taking on leadership roles and possess both introspection and humility, which are foundational for growth. You need people ready and willing to learn.
Right time, right mindset.
Exactly. Second, securing high-quality speakers from the business, legal, creative, and medical worlds is essential to provide a diverse and well-rounded perspective. Not just doctors talking to doctors. These experts should cover a broad range of topics, including leadership overall, strategy, finance, management skills, effective feedback, and coaching techniques. Third, constructive criticism is absolutely essential and must be integrated into the program for genuine professional development. People need honest feedback to improve. The desired outcomes are for surgeons who complete such programs to become proficient in team-building skills and management and emerge as self-empowered individuals. Ultimately, this training should begin early and continue throughout residency, allowing residents to continually adapt and refine their leadership styles based on the specific task challenges and their developing confidence. It needs to be longitudinal.
This directly connects back to patient safety, which you mentioned earlier. Can you elaborate on exactly how stronger non-technical skills improve patient safety? What's the mechanism?
The link is direct and powerful. Patient safety, including all-cause 30-day mortality, is measurably improved by stronger non-technical skills. Specifically, core leadership-related non-technical skills such as clear and effective communication, acute situational awareness, robust team skills, and decisive decision-making are all correlated with reduced surgical errors. Interestingly, interruptions, such as needing to answer a page during an operation, are identified as the only non-technical factors in surgical error not directly attributable to a surgeon's leadership style.
So basically everything but unavoidable interruptions comes back to leadership.
Largely, yes. That single exception serves to highlight the profound, pervasive influence of a leader's non-technical skills on patient outcomes and overall safety.
Okay. Now, a critical area that still seems to be lacking, despite strong interest from most program directors, is formal ethics training in surgical residency. The source says there's no standard curriculum to formally train surgical residents in ethics. That seems like a big gap.
It's a significant and concerning oversight, given the incredibly complex ethical dilemmas surgeons face almost daily. Proposed solutions to address this gap include a case-based approach, where monthly, hour-long ethical dilemmas are discussed in an informal, non-hierarchical setting, fostering open dialogue and diverse perspectives without fear of judgment. Another promising solution is an ICU-based simulation model specifically designed for teaching compassion and end-of-life ethics.
Simulation for ethics. How does that work?
This innovative approach allows residents to have their first, often difficult, end-of-life conversations with standardized patients, actors trained to portray patients or family members in a controlled, simulated ICU environment. It provides invaluable experience without the pressure and potential harm of doing it for the first time with a real family in crisis.
Wow, that sounds incredibly valuable.
It does. These practical, immersive approaches offer a pathway to address this crucial training gap in ethics.
Building on that, the rapid advancements in leadership skill development and evaluation through simulation generally, and the objective structured clinical examination, or OSCE, seem to be incredibly promising tools for the future of training these non-technical skills.
They truly are revolutionary. Over the past decade, our ability to both develop leadership skills, particularly through immersive simulation, and to rigorously evaluate them through tools like OSCE, has increased demonstrably. Multidisciplinary teams, including nurses, anesthesia groups, and surgeons, are now systematically assessed for leadership-associated non-technical skills like communication, teamwork, and situational awareness. And crucially, these complex, non-technical skills have been found to be trainable, meaning they can be learned, practiced, and improved through targeted interventions.
So these aren't just innate traits, they can be taught and measured.
Precisely. The OSCE, in particular, has become the gold standard for training and assessing a wide range of clinical and non-technical skills with remarkable reliability and validity. It was originally developed by Harden in Dundee, Scotland, and first published way back in 1975, specifically to address the pervasive lack of a reliable method to evaluate clinical abilities in medical education at the time. Early versions assessed not just foundational skills like history taking and physical examination, but also critical non-technical skills, patient interaction, and professionalism. Since its inception, it has matured significantly, been subjected to rigorous tests of reliability and validity, and has seen widespread adoption across medical education globally.
So it's a well-established tool now.
Very much so. OSCEs now represent a critical portion of resident evaluation in many programs. They have been well validated for teaching leadership skills in high-stress scenarios like trauma response and in situations involving difficult simulated patients, such as breaking bad news, dealing with angry patients, or simulating disagreements among providers. The extraordinary potential of OSCEs to effectively train, meticulously test, and refine non-technical skills like leadership is immense.
Has it been adopted widely?
Internationally, the Medical Council of Canada adopted an OSCE pilot project back in 1988 for evaluating international medical graduates. This innovation ensured a baseline proficiency of skill, attitude, knowledge, and other non-technical skills for practitioners entering their system. In the U.S., the USMLE Step 2 Clinical Skills CS examination, a rigorous required component for medical licensure, was directly inspired by the OSCE. It's a thorough 12-station, 8-hour exam that has proven to be valid and comprehensive. Osteopathic students also undergo a similar Level 2 performance evaluation.
And they're reliable.
For reliability, extensive data suggests an OSCE should be between 3 and 6 hours and 8 to 10 stations to achieve reliable scores, R value 1.7, for communication, history, and physical examination. At least 7 cases are generally needed per domain for consistent reliability. The ACGME mandated the use of OSCEs in residency programs starting in 2003. While initially met with some wariness from residents, maybe seeing it as just another test, their perceptions did change to reflect an acceptance of its use for grading both technical and non-technical skills. Data from OSCEs typically shows a rapid progression of technical skills correlated with postgraduate year of training, but clinical skills improve at a more moderate rate, highlighting distinct learning curves for different types of skills.
Beyond OSCEs, there's been an explosion in simulation technology and research in the last few years. How is that impacting leadership training and assessment, particularly in surgery? This sounds like the real cutting edge.
This is truly the cutting edge and represents the future of medical education. For example, the non-technical skills for surgeons, not CSES tool, used in simulation, has shown that higher non-test scores are directly associated with quicker resolution of the simulation crisis in high-stakes scenarios like hemorrhage control and airway emergencies. Better non-technical skills lead to better crisis management. Advances in simulation are also teaching incredibly difficult physical examination skills, such as accurately detecting breast lumps or prostate or rectal cancers in a controlled, repeatable environment. Standardized practice. Interestingly, studies show that even experienced attending surgeons benefit immensely from continued simulation practice to keep their operative skills fresh and prevent decline, particularly during periods of dedicated research time or heavy administrative duties when their clinical operative volume might temporarily decrease. Use it or lose it applies here too.
Keeps everyone sharp.
Exactly. The Objective Structured Assessment of Technical Skills, OSCEs, originally developed as a bench station exam, is now being effectively applied to intraoperative skill assessment. It can be mixed with non-technical exercises for a more real-world, comprehensive simulation scenario. Modern assessment tools, like a real-time mobile web system called UpTrust, are allowing for efficient, consistent, and structured assessment of resident operative performance right after a case. These systems are incredibly efficient, taking an average of just 2 minutes of faculty time, and they effectively track performance trends with postgraduate year, fulfilling both ACGME and American Board of Surgery mandates for continuous evaluation.
What about stress? Does that affect these skills?
We know that non-technical skills often erode during stressful events, such as unexpected bleeding, the demands of complex operations, severe time constraints, equipment problems, insurance roadblocks, or the emotional toll of critical illness or delivering bad news. Stress makes it harder to perform well non-technically. Video analysis of actual operations shows that attending surgeons typically take over, change their style of leadership, and decrease their teaching when unintended or stressful events occur, highlighting how stress can negatively impact leadership and training moments.
So simulation helps practice under pressure without real-world consequences.
Precisely. Simulation can also specifically and profoundly improve communication skills. Using simulated patients and immersive training effectively improves interview techniques and empathetic communication, with lasting positive impact even 12 months after training. Finally, there's a fascinating positive feedback loop. Surgeons who rate their own technical skills highly are more likely to engage in positive leadership skills, including actively teaching in the OR, confidently handling difficult situations, and giving clear instructions. Confidence in technical skills seems to enable better leadership. It reinforces the idea that simulation is critical for preventing technical skill decline, especially for residents on research time or attendings with heavy administrative duties. It represents the future of medicine. Though it's fair to say medicine still has much ground to make up compared to other high-risk, high-performance fields like the military, space exploration, and aeronautics, which have long embraced simulation as core training. Modern surgical leaders must absolutely recognize its criticality for training and continuous performance improvement. #tagged measuring performance and the role of mentorship.
With all these complex skills being developed and honed, there's also a significant and growing focus on evaluation of surgeon performance. We're talking about numerous organizations assessing both technical and non-technical skills in real time, often with direct links to compensation, promotion, and even professional discipline. It's high-stakes evaluation.
This is a critical area of accountability and continuous improvement, absolutely. The source provides a comprehensive listing of these various organizations and programs, and it's important for you, the listener, to understand their distinct roles in the ecosystem of surgeon evaluation if you want that elite understanding. Let's run through them. First, the Hospital Consumer Assessment of Healthcare Providers and Systems, HGAHPS. This is a crucial public reporting initiative that systematically collects and measures patient perspectives on and satisfaction with hospital care. It primarily evaluates non-technical aspects: communication with nurses, doctors, responsiveness, pain management, medicine communication, discharge info, care transition, publicly reported patient views.
So direct patient feedback impacting hospital ratings.
Exactly. Similarly, the Clinical and Group Consumer Assessment of Healthcare Providers and Systems, CGCHHPS, focuses on patient perspectives and satisfaction, but specifically in an office or outpatient setting. Again, evaluates non-technical skills. Access to care, provider communication, test results delivery, office staff helpfulness, overall provider rating, focus on the clinic experience. Then we have DATIX, incident reporting. This is usually an internal database system designed to systematically record and analyze incidents within a healthcare organization to improve overall reliability and patient safety. It promotes a culture of ownership over mistakes and transparency. It evaluates both technical and non-technical aspects, looking at system issues, patient safety quality problems, provider behavior, and leadership style influences, learning from mistakes.
Okay, internal tracking.
Right. The Patient Advocacy Reporting System, PERS, compiles patient complaints into a comprehensive physician index. Its purpose is to identify physicians who may pose a high malpractice risk, due often to behavioral patterns, specifically unprofessional behavior like being disrespectful or rude. primarily non-technical focus on conduct. The coworker observation reporting system provides a structured mechanism for physicians to document instances of unprofessional conduct observed in colleagues. Think peer reporting. This data is then used to provide constructive feedback and facilitate behavioral change. It evaluates both technical and non-technical unprofessional behaviors, like being disrespectful or engaging in unsafe practices.
Peers watching peers for safety and professionalism.
Correct. The American Board of Surgery, ABS, Maintenance of Certification, MOC program, is designed to ensure a surgeon's ongoing commitment to professionalism, lifelong learning, and continuous practice improvement throughout their career. This involves a comprehensive evaluation of both technical and non-technical aspects, verifying medical license hospital privileges, documenting CME, self-assessment activities, cognitive expertise exams, and quality assessment program participation. Ongoing board certification requirements. Hospital Compare, part of CMS, provides public information on hospital performance and quality, largely using HTA-HPS data. So, again, predominantly non-technical aspects, making performance transparent to the public consumer.
Public scorecards.
Yes. The Federation of State Medical Boards, FSMB, represents the state board's licensing physicians. They oversee conduct, evaluate medical knowledge, investigate patient complaints, and address law violations, thus assessing both technical competence and professional non-technical conduct. The licensing bodies. Internet clinical scores, found on popular review sites like healthgrades.com, ratemds.com, Yelp, offer direct, unfiltered patient opinions. These platforms primarily evaluate non-technical skills and patient experience, professionalism, communication, timeliness. Patient reviews online.
The Wild West of reviews sometimes.
Can be. The Hospital Acquired Condition Reduction Program is a significant government initiative linking financial incentives or penalties to hospitals based on reducing undesirable patient conditions during a hospital stay. This program heavily evaluates outcomes often linked to technical aspects. Retained foreign objects, air embolisms, blood incompatibilities, pressure ulcers, falls, poor glycemic control, catheter infections, surgical site infections, DVTs, PEs, pneumothorax. Mostly technical failures with financial consequences. The American College of Surgeons National Surgical Quality Improvement Program, ACS and SQIP, is a robust, data-driven program collecting data on risk-adjusted preventable surgical complication rates. Its purpose is quality improvement through data. Primarily evaluates technical aspects, surgical complications, SSIs, UTIs, readmission rates, outcomes, surgeon-specific quality data.
Detailed surgical outcome tracking.
Yes. Finally, the Centers for Medicare and Medicaid Services Surgical Care Improvement Project, CMS-SCIP, collects data on surgical complication rates based on established guidelines. It predominantly evaluates technical complications, infection, cardiac, venous thromboembolism, vascular respiratory complications of surgery, focused on specific post-op complications.
That is an exhaustive and incredibly thorough list. It truly drives home the comprehensive and multi-layered nature of modern surgeon evaluation and accountability, and the source notes that this is, in fact, the first comprehensive listing of such agencies detailed in one place. Very valuable for understanding the whole picture. Beyond these formal evaluations, mentoring is introduced as a crucial, perhaps even indispensable component of formal leadership training, not just evaluation, but development.
Mentoring is indeed a cornerstone. It is defined as the active process by which an experienced, empathetic person guides another individual in the development and self-recognition of their own vision, learning, core competencies, and professional development. It's a guiding relationship. The historical context traces back to the legendary William Halsted, who established the concept of a surgical mentor, emphasizing clinical decision-making based on scientific evidence to develop outstanding leaders and innovators. Modern mentors, however, extend far beyond just technical skills. They also serve as vital role models, demonstrating effective communication, deep empathy, profound humanism, and the crucial prioritization of competing professional and personal activities.
Yeah.
The whole package.
So it's different from just teaching or coaching.
Yes, it's important to make a clear distinction. A teacher passes on a defined level of knowledge, implying a limited level of advancement within a specific curriculum. A coach, on the other hand, has the sole purpose to make his or her student the best at their game, with an unlimited level of advancement, pushing boundaries and unlocking full potential. Dr. Paul Ward, for example, truly embodied the role of a surgeon's coach, as he had more than 25 former residents become chairs of surgical departments. That's incredible impact.
Wow.
A mentor, however, involves a greater level of trust and commitment than a teacher. It's a genuine partnership, an experienced and trusted advisor who provides holistic guidance across career and life.
What makes a good mentor?
The responsibilities of an effective mentor: as eloquently summarized by Berendis, include demonstrating empathy, maturity, self-confidence, resourcefulness, and a profound willingness to commit time and energy to the mentee's growth. They must actively offer guidance, stimulate, and challenge the mentee's thinking, encourage self-realization, faster growth in all dimensions, and make more comprehensible the complex landscape of their profession and career. They help you navigate. Mentors assess aptitudes, help refine leadership skills, and significantly expand the mentee's vision for their future. It is strongly noted that highly successful surgeons most often have had excellent surgical mentors, and over 50% of United States Nobel laureates in science were, in fact, mentored.
That's a powerful statistic. Mentorship matters.
Hugely. Mentorship offers profound benefits for both mentees like enhanced research productivity, increased grant funding, securing desired positions, and for mentors who experience a refinement of their own skills and deep personal satisfaction from guiding others. Therefore, mentorship is essential and should be included as a formal, integrated component of leadership training programs. It needs to be built in.
Now, let's consider the very beginning of a surgeon's journey. Medical students. They typically begin their medical education with great empathy, excitement, optimism, and an idealistic vision for their future in medicine. But there's a real concern that they can lose that initial spark, sometimes viewing the patient-physician relationship almost as an afterthought or a secondary concern compared to the scientific knowledge. The cynicism creep.
This is where the concept of the hidden curriculum becomes incredibly relevant and impactful. This refers to the informal social norms learned by students implicitly, based on their observations of resident and attending behavior. It's not explicitly taught, but absorbed through observation of how things are really done.
Learning by watching.
Exactly. It cannot be eliminated, as it's an inherent part of learning within a social structure, but it absolutely can be studied and unmasked to ensure it's having a positive influence, not a negative one. Medical students, consciously or subconsciously, constantly look to their mentors, residents, and attending surgeons for cues on how to conduct themselves as physicians. Whether or not the witnessed behavior is a positive example, the student will begin to perceive that behavior as normal and acceptable.
Monkey see, monkey do.
Essentially. Professional norms, such as adhering to the Hippocratic Oath, demonstrating respect, upholding ethical principles, ensuring accountability, showing genuine empathy, and practicing altruism, are modeled, for better or worse, in every personal encounter and interaction they observe. It's crucial for residents and attending surgeons to understand this constant observation and the profound influence they wield as role models. They're always teaching, even when they don't think they are.
What about that empathy decline you hear about?
A critical and well-documented observation is that during their clinical years, particularly from the third year onward, medical students experience an exponential growth in knowledge, but paradoxically, a measurable decline in empathy. While the initial excitement of first patient encounters and hands-on learning is high, the rapid pace, intense experiences, and emotional demands create significant stress. As familiarity and comfort with clinical problems increases, the excitement and wonder experienced by the student decreases, sometimes leading to a more detached, maybe even jaded approach.
Keeping that compassion alive is key.
Absolutely. However, even the most routine clinical work demands extraordinary attention to detail and compassionate care, every patient, every time. This consistent, unwavering dedication is the hallmark of the true professional. The Carnegie Report in 2010 critically called for medical education to actively promote the progressive formation of the physician's professional identity. In response, many medical schools are now emphasizing early professional education and integrating professional identity formation throughout their curricula. The Liaison Committee on Medical Education, LCME, which sets standards for medical school accreditation, specifically requires administrative and faculty leadership in this area, and mandates that schools provide robust career exploration, mentoring, and advising programs. A longitudinal leadership program beginning at the onset of medical school can powerfully establish a consistent pattern of ethical behavior, professionalism, work-life balance, wellness, and strong character. So while medical students will naturally trade some initial idealism for a refined vision and a strong professional identity shaped by experience, formal training and positive modeling by residents and attendings can crucially ward off the empathy decline and ensure they develop into well-rounded, compassionate leaders.
It's one thing to teach and practice leadership, but how do we objectively measure its outcomes in healthcare, especially for those elusive, non-technical skills? Sounds like a significant challenge. How do you quantify good leadership?
It is a challenge to quantify the intangible, but there are increasingly sophisticated and established tools to do so. The Multi-Factor Leadership Questionnaire, MLQ, is a widely used instrument that differentiates between transformational and transactional approaches of leadership.
Transformational versus transactional. Quick difference.
Transactional leadership primarily focuses on completing and rewarding the tasks, more traditional quid pro quo approach. Do this, get that. Transformational leadership, conversely, emphasizes motivation for completing the tasks and fostering a positive and encouraging working environment through inspiration and vision. Let's achieve this together because it matters. Findings from studies using the MLQ are compelling. Surgeons scoring higher on transformational leadership were consistently more focused on promoting an open environment in the operating room, which directly correlated with greater communication, a vital factor in addressing a leading cause of surgical errors. An MLQ study in 2008 of surgical residents found a significant association between transformational leadership and overall perceived team effectiveness and resident satisfaction. It also revealed that residents often valued individual needs less than team efficiency, suggesting a specific area for training to foster a more supportive and person-centered team atmosphere.
What other tools are there?
The NEO 5-Factor Personality Inventory, NEO, is another valuable tool that explores 5 different personality traits: neuroticism, extroversion, openness to experience, agreeableness, and conscientiousness. The Big Five. A 2011 study using the NEO found that surgical residents scored above the national average on most of the factors, but significantly below average on agreeableness, a trait that measures altruism and tolerance.
Below average on agreeableness. That fits some stereotypes, maybe.
It does align with some perceptions. This finding, correlating with MLQ results, precisely pinpointed specific personality traits that could be areas for leadership modification and development, encouraging more empathetic and collaborative behaviors. Identifying a trait allows you to work on it. The Surgeon's Leadership Inventory, SLI, is a practical, surgery-specific guide, grading surgeons on 8 key elements derived from literature on leadership and surgery and direct observed behaviors. Let's quickly list them for you. Maintaining standards, safe, quality care protocols, asking for help. Making decisions, informed judgments, communicating them. Managing resources, assigning resource tasks effectively. Directing, communicating expectations, confidence, training, educating, developing team members, supporting others, assistance, encouraging open communication, communicating, timely info, getting input, and coping with pressure, flexibility, composure.
A very practical checklist for surgical leadership behaviors.
Exactly. This tool is particularly useful for assessing individual growth and identifying specific areas for improvement in a surgeon's leadership journey. Additionally, systematic patient feedback is a powerful measure. Patient complaints are inversely related to leadership effectiveness and can be used as direct data points to improve leadership and communication skills. Listen to your patients. The Objective Structured Clinical Examination, OSCE, with its controlled environment, direct attending feedback, and videotape sessions, provides an excellent platform for self-reflection and targeted improvement of non-technical skills, as we discussed. Finally, the Consumer Assessment of Healthcare Providers and Systems, CAHPS surveys, collect standardized patient feedback on various aspects of healthcare important to them, like physician communication. The results are often made public, providing transparency and illuminating specific areas for improvement towards truly patient-centered care. Ultimately, the data consistently shows that improved leadership, as measured by these tools, is associated with better hospital climate, improved performance, and a lower number of complaints, demonstrating its profound and measurable impact. #tag leadership across the career spectrum.
So it's clear that leadership is a lifelong journey in surgery, evolving through different career stages. What advice do current established surgeons offer for prospective surgeons just starting out, perhaps even still in medical school or considering the path? What should they focus on early?
They emphasize the foundational qualities of accountability, resilience, and high personal standards. Prospective surgeons are strongly advised to pursue perfectionism and be self-critical in their craft, but with an important caution against allowing these traits to devolve into neurotic behavior or self-sabotage. Find the balance. Fundamentally, teamwork and learning to take initiative are mandatory in modern surgical practice, and innovation is highly desirable for anyone looking to make a lasting impact. Don't just follow, contribute. For residents who are closer to becoming independent and taking on more direct leadership, the OpTrust tool has been specifically validated to facilitate their transition across 5 crucial domains: questioning, planning, instruction, problem solving, and leadership itself. This helps bridge the gap from supervised trainee to independent surgeon leader.
A tool to help manage that transition.
Yes. Another effective model is the Resident Surgeon Manager Conference, which is truly immersive. It integrates various experience levels, inviting attorneys, business experts, and risk management experts as guest speakers. Exercises are case-based, involve role-playing, simulation, and interactive lectures covering vital topics like teamwork, negotiating techniques, time management, risk management, maintaining balance, giving effective feedback, and creating immediate, goal-oriented action plans. This provides a holistic training ground for the non-clinical aspects of being a surgeon leader.
How does this leadership development continue as surgeons move into their early careers and work to establish themselves, perhaps as new attending physicians? That first job out of training must be tough.
It's a huge transition. One promising method to facilitate continued development, especially for busy early career surgeons, is speed mentoring. This involves 10-minute pairings of senior and junior surgeons answering preset questions at national conferences, offering quick, high-impact mentorship opportunities that fit demanding schedules, like speed dating for mentors.
Quick hits of wisdom.
Exactly. For surgeon scientists, those who divide their time between clinical care and research, the challenges are particularly acute. Beyond the need for perseverance and team leadership for their labs, they face the significant financial challenge of funding research and clinical duties competing for time. It's a tough balancing act. For these individuals, robust departmental support in the form of protected time for research, financial support, and dedicated mentorship is absolutely crucial to their success and ability to lead effectively in both domains.
What about behavior in the OR itself for early career surgeons?
Crucial area. In the operating room, which is the heart of surgical practice, a surgeon's behavior is a constant, clear indicator of their leadership. Good leadership is demonstrably shown by surgeons who are actively trained to collaborate, consult others appropriately, be consistently polite, even simple please and thank you make a huge difference, and proactively create a safe space for their operating room staff to voice concerns without fear of reprisal. Fosters trust and open communication. Conversely, poor leadership manifests through behaviors such as non-constructive criticism, destructive humor, steering conversation away from the current case, and expressing frustration in a way that creates tension and fear.
So that's a bad tone.
Exactly. These behaviors can be further categorized for structured feedback using terms like conductor, elucidator, delegator, engagement facilitator, tone setter, being human, and safe space maker, providing a framework for identifying and improving specific leadership qualities in the high-pressure or environment. Helps give specific feedback.
And finally, for senior faculty, there's a tremendous opportunity to transition into departmental leadership and ultimately to focus on legacy building. This must be a pivotal phase, planning the end game almost.
Absolutely. The presence of experienced senior academic surgeons is an invaluable asset to any department. A formally planned transition for late career, moving gracefully from active departmental leadership all the way to emeritus status, when thoughtfully designed years in advance, can initiate a truly constructive and mutually beneficial process. Planning for succession. This plan should be agreeable to the senior faculty member and departmental leadership and hospital stakeholders to ensure smooth succession and continued contribution. Its benefits are significant, fostering a shared vision, mutual understanding, and clear goals and transition points, which allows the department to strategically look ahead at the future and plan for continuity.
How does recognition play into this?
The recognition of senior academic surgeons through leadership roles, promotions, and the granting of emeritus status plays a crucial role in shaping the values and culture of the faculty body. It signals what the institution values. There's a powerful multiplier effect at play here. One excellent leader trains several, who then go on to train several more until the culture of surgery nationwide is profoundly influenced. This creates a ripple effect of excellence and mentorship across generations, passing the torch effectively.
But there's a sensitive issue here too, right, about aging surgeons?
Yes, a truly controversial and sensitive issue is aging and when to cease practice. Unlike airline pilots who have mandatory retirement ages, there's currently no mandatory retirement age for surgeons. While thankfully few, there are documented reports of physicians continuing to practice after their skills have objectively declined, potentially becoming dangerous to patients, and the profession has, unfortunately, been unable to prevent this consistently. It's a difficult conversation. Some healthcare organizations have begun to implement mandatory cognitive and physical evaluations for older practitioners to ensure ongoing competence.
Testing older surgeons, controversial, I imagine.
Very. However, the chapter's proposed alternative, which is seen as a more palatable and proactive solution, is a formally planned transition emphasizing the values of leadership and legacy building, allowing senior surgeons to transition gracefully while still contributing their invaluable wisdom and experience to the next generation without compromising patient safety. Focus on legacy, not just stopping. Hashtag tag outro.
So, to bring it all together, after that incredibly detailed journey, what are the core insights and key takeaways from our deep dive into leadership in surgery? What should you, our listener, really take away to achieve that mastery we aimed for?
Well, I think the fundamental insight is that surgical practice has fundamentally evolved. It's not the old solo act anymore. It's now inherently team-based, requiring mastery of leadership principles that extend far beyond just technical skill. As important as that is, this kind of leadership demands a clear, inspiring vision and a profound willingness. The willingness to lead, to commit to lifelong learning, to communicate effectively, and to skillfully resolve conflict. And crucially, these are not just innate traits you're born with. They are cultivated abilities, honed through dedication, training, and practice.
And what's truly compelling, I think, is how effective leadership is bred through its training programs, or at least how it should be. It really underscores the urgent imperative for innovation in surgical training programs to continuously shape the future of surgery amidst rapidly evolving science, technology, and complex healthcare systems.
Absolutely. Ultimately, this comprehensive understanding shows us how effective leadership directly translates to improved patient care, enhanced productivity within the team, and frankly, a healthier, more supportive work environment for everyone involved. It benefits everyone.
So for you, our listener, given the profound and undeniable impact of leadership on patient outcomes and the well-being of healthcare teams, we invite you to consider this final provocative thought. How might the principles we've discussed today of vision, willingness, communication, adaptability, emotional intelligence, all of it, extend beyond the operating room to other high-stakes, collaborative environments in your own professional life? How could they fundamentally shape the future of your field? We encourage you to reflect on that question and carry these insights forward into your own leadership journey. Thanks for joining us on the Deep Dive.